Hello everyone. In this video we will be talking about prenatal genetic screening. This is very crucial topic for the pediatric surgeons, pediatricians as well as the gynecologist or the obstetricians. The young patients who are in the initial phase of pregnancy will also be having a benefit out of this learning. So starting in 1970s, maternal serum alpha fetoprotein was initially used for detecting the needle tube defects in the fetus. Later on in 1980s, aneuploidy disorders, chromosomal disorders, were also screened by using the serum markers using the maternal blood. Later on, trisomies like Tau syndrome, trisomy 13, trisomy 18, Edwards syndrome, microdeletions, sex chromosome disorders, and carrier screening was also undertaken. Carrier screening for other diseases like cystic fibrosis, hemoglobinopathies, thalassemia, and others are also being done. So, as a recommendation, prenatal genetic screening should be recommended to all the antenatal patients. In the beginning of their antenatal period, they should be counseled and recommended, despite of the risk factors being involved. So, what are the markers that are used for these screening tests? Maternal serum alpha fetoprotein, then pregnancy associated plasma protein A, PPA, then free beta human chorionic gonadotropin, beta HCG, inhibin A, and unconjugated estradiol is the other one. These are the 5 markers that are generally used for the screening purpose. During the first trimester, the investigations that are done using dual marker, that is pregnancy associated protein, plasma protein A, PP, and the beta HCG is used as dual marker screening, and cell-free DNA testing can also be provided to the patients in the first trimester from 10 weeks to 13 weeks of the gestation age. In this screening using ultrasonography, there is the knuckle translucency is seen, and embryo is checked for nasal bone ossification. During the second trimester, from 15 to 22 weeks, there are the screenings included as triple marker assessment. Triple screening measures beta HCG, serum alpha fetoprotein, and unconjugated estradiol. Quadruple marker assessment includes inhibin also, and in pentascreening there is the role of hyperglycosylated human chorionic gonadotropin. More commonly used is the quad screening, followed by the triple assessment, and rarely the pentascreening is needed in the patient. So one should understand that all these tests are screening tests rather than the diagnostic tests. So the values given by the various parameters are considered and classified into low risk, intermediate risk, or the high risk for the specific disease or the anomaly. So remember that these are never the diagnostic tests, and these screening tests cannot rule out any disorder or cannot prove for the disorder as 100% authenticity. So coming on to the results of these screening tests, during the first trimester, the dual marker screening is done, and along with the knuckle translucency. So in this, PAPPA level is usually decreased in all the trisomies, that is most common Down syndrome, Edwards syndrome, and the Tau syndrome, T21, T18, and T13. Beta HCG is typically decreased in Edwards syndrome, while it is increased in trisomy 21. Knuckle translucency is greater than 3 mmF, then it is abnormal. So during second trimester, the maternal serum analyte screening results are categorized as low risk, or high risk based on the findings that we get for the specific trisomies. For trisomy 21, it is associated with low alpha fetoprotein and high beta HCG, as well as high inhibin A, while PAPPA is low. In Edward syndrome, that is trisomy 18, it is associated with low serum alpha fetoprotein, low estradiol level, low beta HCG, and normal inhibin A will be there, as well as the low PAPP A is there. In trisomy 13, it is associated with normal alpha fetoprotein in the maternal serum. Then normal estradiol level will be there, normal beta HCG will be there, normal inhibin A can be there, and there is low pregnancy associated plasma protein A. We need to always remember that level 2 ultrasonography is the essential for looking for any of the structural anomalies in the fetus. Ultrasonography should be provided to every patient for looking for the structural anomalies. So, what is NIPS or NIPT? That is the non-invasive prenatal screening, and this screens for cell-free DNA and is available 10 weeks onward gestation. So, this provides the highest detection rate of the anomalies and is diagnostic as well. So, cell-free DNA is the fraction is the fetal fraction of the DNA that originates from the placental trophoblast, which releases the DNA fragments into the maternal circulation. The fragments are isolated and purified from the maternal plasma for the further analysis. So it depends upon the sufficient fetal fraction of the cells that you have got from the maternal serum, and for the accurate analysis. Minimum fetal fraction that is required or that is liable for cell-free DNA screening is 4%, 2 to 4%, and maternal weight can affect the fetal fraction. So NIPS or the NIPT is the non-invasive prenatal test that is carries a diagnostic significance as well as is used for the screening purpose. This detects the floating fetal DNA in the maternal serum. Now coming on to the invasive prenatal tests, these are usually the diagnostic tests, and in case of the high risk patients who have undergone already the quad screening or the dual marker screening, and there is the chance of anomaly, genetic anomaly in the patient, then these undergo the invasive testing for the diagnostic purpose. So in this, fetal cells are taken from the amniotic fluid or placental tissue, that is chorionic villi sampling, or fetal blood can be taken through the cordosynthesis. In chronic villi sampling, this is done usually from 10 to 14 weeks, and it can be done transabdominal as well as transcervical. Then comes the amniocentesis. This is done from 14 to 20 weeks in the second trimester and is done both transabdominal, transcervical. It can be done. There comes the rapid test, and rapid test report that comes within 3 days, while the detailed report might take 2 weeks to come in these patients. Invasive prenatal screening using the fetal blood as the sample. In these patients, the fetal blood is taken from either by the cordosynthesis from the umbilical cord, percutaneous umbilical blood sampling (PUBS), or the cardiosynthesis can be done. In this, the fetal blood is taken from the heart, or intrahepatic blood sampling can be done for the purpose. So talking here about the combined screen test or the first trimester combined screening FTCS. This is done in 11 to 14 weeks gestation and combines the following for the risk assessment of trisomy 21, trisomy 18 and trisomy 13. One is, as discussed before, free beta HCG and PAPPA. Second is ultrasonography for knuckle translucency or the nasal bone ossification. And third one is maternal age. These for the risk assessment or the risk categorization of any pregnancy for the these aneuploidy disorders. So key lessons to remember in this discussion are maternal serum markers that are used for the categorization of the risk assessment are always screening tests, not diagnostic, while as invasive tests and the non-invasive tests are available in the form of cell-free DNA for the diagnostic purpose during the antenatal period. So in invasive prenatal tests, karyotyping can be done, DNA sequencing can be done to diagnose the disorders properly during the antenatal period. Thank you for watching this video, and I hope this video will be very valuable for the listeners.